So welcome, listener, to the Coriel Ortho podcast with me, Tony Wilkinson, consultant podiatric surgeon, foot surgery expert, and founding director of Coriel Orthopedic Group. Now, this is a podcast where we delve into everything medical, surgical, and health and well-being related. And today I'm delighted to be joined by my friend and colleague, Paul Haslam, who goes by the name of Paul Haslam Knee Surgeon on Facebook, and he is a specialist orthopedic surgeon in knees. And we're going to delve into quite a few things really associated with knees, because I really want to know about conservative management of the knee, different types of injections you can have, because that seems to be a whole explosion of the industry in treatment of the knee. We're going to talk about knee replacements and whether robotic knee replacements are actually a good thing or not. And then some of the soft tissue injuries, including the good old ACL, and also touch on things like Baker's cyst, as well as maybe cover a little bit about children's knee problems as well. So welcome, Paul.
Thanks, Tony.
What amazes me about your practice is just how busy you are. Because most orthopedic surgeons will have more than one specialty. So they might do shoulder and elbow or hand and wrist, but have a wider range. But you just specialize in knees. But yet you're so busy. How did you end up becoming a knee specialist? And did you know about that before you chose that specialty?
So I suppose going back in time, there's many choices you make in life. The first choice is to do medicine, and then within medicine you choose to do surgery. Well, I like doing things, and so being busy is part of my makeup. The first choice you make is you go for surgery, and then within surgery there are many opportunities. Orthopedics always appealed to me, and then within orthopedics, I suppose you have many different joints. I suppose the knee chose me rather than I chose the knee.
Yeah.
I always found that more interesting. Everyone's heard of sports, men and women that have injured their knee. It's relevant to daily life. It's a specialty where you treat patients from cradle to grave. So you can treat patients from almost the moment they're born right up to the end of their life. So there is a vast array of different treatment options within the knee joint. In terms of the busyness, I found that the less I do, the busier I got.
Yeah.
And I think these days, especially, people want to see a specialist who knows that joint inside out. Yeah. And so narrowing down to one joint, I think, is for me very important, so that you can keep up to date with the latest developments in the field. You can do a good number of cases in each of the different operations. And there are many facets to the knee. You know, the knee is not just a simple hinge joint. Yeah. There are bony structures, there are soft tissue structures, the kneecap, which is an area of interest of mine. And so, yeah, I hope that explains the reasoning behind.
So quite a complicated structure. So I suppose when people really think about knee surgery, most people will think about a knee replacement, for example. And I remember speaking to you and you almost giving me the impression that you were doing less knee replacements and more soft tissue and other types of treatments to the knees, which just goes to show you how much you potentially can do to the knee, given the fact that you are so busy. But looking at knee replacements, I mean, that's a very common operation these days. Why is it not an operation that every orthopedic surgeon could do? Because back in the day, an orthopedic surgeon, everybody would do a knee replacement. Is that, are people moving away from that, or is that still an operation that everyone can do?
So I think there are two groups of surgeons that would offer a knee replacement. There are knee surgeons that are trained just on the knee, and then there are what we call arthroplasty surgeons who are joint specialists, and they would commonly do lower limb arthroplasty, and lower limb arthroplasty really is the hip and knee replacements. And then you develop an interest within that. There is even within a knee replacement, there's a vast difference between a simple knee replacement and a more complex one. And also we haven't touched on yet is a partial knee replacement. Yeah. And so as a predominantly a soft tissue knee specialist, my practice focuses mainly on partial knee replacements and total knee replacements. And I think soft tissue knee surgeons generally do more of the partial knees than the arthroplasty surgeons would, the hip and knee specialists. And I am a big proponent of a partial knee replacement.
Is it a more complex operation, the partial knee?
It's a slightly more fiddly one. And I suppose everything in life has pros and cons. And so if you are suitable for a partial knee, the results suggest that you are likely to get a better functional outcome. What does that mean? Well, functional outcome means I can do stuff. So if you're a golfer, if you want to play tennis, you're more likely to be able to do that more easily with a partial knee if that's what you're suitable for, rather than a full knee. Now, lots of people do function at a high level with total knee replacements, but you're more likely to enjoy and be able to do your sport more effectively if you have a partial knee.
So when you're talking about a partial knee, then I'm thinking in my head here what the public might be thinking is, so it's half a knee basically. So is it half a tibia and half a femur, or is it the other way around? It's half a condyle and half a tibial plateau, or is it just a femoral side and no tibial side, or what do you mean by partial knee?
It might be usable to demonstrate on the knee model. So this is a knee joint. We can move the patella out of the way because that at the moment isn't relevant to this conversation. And what you can see is there are two sides to the knee joint. So these are what we call the condyles of the femur bone, the thigh bone. And in very simplistic terms, the knee is made where the femur and the tibia come together, and it acts a bit like a hinge.
Yeah.
I think the vast majority of patients that I do partials on would have medial or inside compartment osteoarthritis. Right. And you would replace both sides of the joint. So you remove the slither of bone from the tibia and the slither of bone from the femur, which is then shaped, and a plastic component would fit between the two metal components.
Okay.
You can do that also on the lateral side, but that's the outer side. That's less commonly done. And then with a full knee replacement, you replace the whole lot.
Okay. Because in my profession, in terms of joint replacements, the big toe is the most common one that's replaced, and you can get half a big toe joint, but it's actually either the big toe side or the metatarsal head side. But that's not what we're talking about in knees. We're either talking the inside basically or the outside of the knee, and that's because one side might wear down more than the other. So is that related to somebody who's, say, got bow legs or knock knees?
Yeah, that's absolutely correct, Tony. So so the what we call a malalignment or a slight malalignment causes overload of one compartment,
right,
and spares the other one, and so that leads on to wear and tear eventually, and necessitating the need for replacement.
Okay, so in somebody who's younger then, who's starting to develop arthritis, and they've got either a knock knee or a bow leg, what can you do with them? Can you cut the tibia or the femur and change the angle of the leg and then preserve the knee from arthritis? Is there evidence to say that if you intervene early you can prevent arthritis, or is it once it's started then it's going to go anyway? What point would you try and save it, and what point would you say you need a knee replacement or a partial knee replacement?
So what you're talking about is the option of an osteotomy. So osteo means bone, and osteotomy is to break or reset, and which used to be a very common operation before knee replacements were developed in the 60s and 70s.
Well, even for severe arthritis.
Even for severe arthritis. That fell out of favour a little bit, but actually osteotomy there's a lot of interest in osteotomy. It's been rekindled with more modern techniques, and it's becoming more common and more popular again. So the target market really for osteotomies would be younger patients who want to remain active, who don't want a knee replacement. So we're looking at somebody perhaps who's 40, who's very active, who's already got quite established arthritis, who may have, as you say, bow-legged or knock-knee deformity. And then you can correct that at the knee. It offloads the damaged part of the knee and overloads the good bit.
Yeah.
It's very important that these patients are properly assessed. So you'll need to have what we call a mechanical axis X-ray, where the hip, knee, and the ankle are taken in a straight line.
Yeah.
I normally do an MRI scan as well, just to check that the other parts of the knee are normal, because we don't want to overload a compartment that can't take it, and then you very slightly overcorrect them. This is all carefully planned preoperatively, and it can be a very successful operation.
So you're either going to open a wedge up and put some bone in, or close a wedge down and take some bone out. So I suppose there's two questions that, if you're putting bone in, where do you get the bone from? And secondly, if you're changing that, do you make the leg longer or shorter? And does that have an impact? Does that cause problems?
So no, I've never had a patient complain that their leg lengths are unequal after a simple knee osteotomy. And in terms of taking the bone away or adding bone in, it doesn't. You don't have to put any bone in, so you can leave a gap which will fill in. Although the majority of occasions, I do insert what we call an allograft, which is bone from somebody else who doesn't need it anymore, which has been specially cleaned and prepared. And I find that makes the technique very simple.
Yeah.
Because you pop the bone in, it holds the correction. You pre-plan it. Let's say it's a 10 millimeter correction. You get your wedge that's 10 millimeters. You put that in exactly the right place, and you fit the plate on it. And I found that the allograft, we call it allograft, that's the extra piece of bone, the bone wedge, works very well. Makes the technique very simple and reproducible.
Right, okay. So if people are having a knee replacement, I mean, knee replacements must have moved on in terms of the quality of the implant and the type of things and the mechanical. Funnily enough, I was watching a program on Netflix the other week. I think it was called Full Man or something like that. But basically, this guy went for a knee replacement, and he was a multimillionaire, and he was in America. And he said to the surgeon, "Well, I just want the best knee you've got." And he said there was this hydraulic knee on the market, which almost had like a robotic movement to it. And I thought it was a bit of a joke, really. But I just thought, I wonder whether that sort of thing will come, whether there would be assisted movement in knees, some sort of electronics. Any of that on the horizon with AI and all of the other stuff that's coming along? Or is it just a pipe dream?
I'm very skeptical about anything new. And the problem with knee replacements is it takes a long time to prove that anything new is better. And the gold standard for the UK market, and we are very good at monitoring knee replacements, is 10-year follow-up. Yeah. So you really, unless you've got 10-year follow-up, you're part of an experiment.
Right.
And a lot of new things are worse. There's been lots of examples of this over many, many, many years. So at the moment, there's a lot of focus on navigation and robotics surgery.
Right, okay. Yeah. So, I mean, that's marketed quite heavily, isn't it, now? I think.
So, I'm yet to be convinced the clinical evidence, i.e. the patient-reported outcome measures, whereby this patient with the robotics compared to this patient with non-robotics, I'm yet to be convinced that data yet exists. That makes it worth all the extra trouble, because it takes a lot longer to a robotic knee. You need to drill pins in around the bone above and below the knee. Yeah. So there's an extra potential morbidity or potential complications from that. And obviously the time factor, which means a longer operation, there may be more risk of more complications. So at the moment, I have looked at robotics. I've done them in the lab. It may be something we introduce into our practice, but I'm sitting on the fence a little bit because I'm not yet convinced it makes that much difference.
So when we're talking about robotics, we're not talking about you sitting outside the theatre and using a robot to do the operation, like in some operations. We're talking about a guided knee replacement, really, based on CT scans, I presume.
Well, it's based on intraoperative markers. So the pins you would drive the pins in, and that would then reference. Okay. And the robot would reference off that. You then have to sort of colour in the knee. Right. And tell the robot which bit of the knee that is. Right. And there are certain markers you would put. So what we do know is that robotic knee surgery is good at getting the alignment right. Yeah. And it prevents you from, for example, taking too much bone off. So it will stop. So the different systems will just not let you cut too much off. Yeah. And so there is.
So you're reducing the risk of taking too much bone away and implant failure because of that, or implant poor position, you think?
I suppose the theory is that if it's more accurate, it's likely then to lead on to better outcomes. Right. But I'm still waiting for that data.
Right. Okay.
I am interested in custom-made knee replacements. So there is different ways you can look at innovation. There is a knee replacement on the market called Conformis, which has excellent NGR data, which is actually
that's the National Joint Registry.
That's the National Joint Registry. Okay. Sorry, I shouldn't use acronyms. Yeah. And that is based on a CT scan of the patient. Yeah. Patient's images are transferred over to America, and the prosthesis is made for that individual patient. Yeah. So I have done a number of these cases, and the results are very good. So that's something at the moment that I'm more interested in rather than robotic knee surgery.
Right. Okay. So touching on the National Joint Registry then, so that's something that you fill in after you do every knee replacement. It's an audit trail essentially. I take it.
So that keeps track of the surgeon, the hospital, and the implant.
Is that something patients can access to get information on the surgeon and quality outcomes?
Yes. So it's publicly available data. So only the number of cases that the surgeon's done would be published on the NGR.
Okay.
for that calendar year.
Right. Okay. Interesting. So moving on then. So when we start talking about soft tissue knees, I suppose most people will then think about the old ACL injury, because everyone knows a footballer who's had an ACL injury. People have had a lot of skiing injuries and had an ACL injury. And I suppose you can have a PCL one, which is the ligament behind it. I suppose that's less common, but you can tell me about that. But one of the questions I want to know is it worth having your ACL repaired, or could you just manage it and it gets better by itself? Because sometimes with ankle injuries, when you get the ATFL, the one around the ankle that you twist, often physiotherapy and strengthening and the body just dealing with it can make a difference. Is that the same with the knee, or do you think that it's something that should be treated?
I suppose it's like everything in life, it depends. I think we'll go back to the knee model again, just to show what the ACL is. So A is anterior, and that means front. C is cruciate, and that means cross. And ligament is a stringy bit which holds the bones together. So the ACL starts at the front and it goes to the back of the knee. So it starts at the front on the tibia, which is shin bone. So it's that structure there. I don't know if you can see that very easily. So that structure there. So it's an oblique structure, its action is to prevent the tibia moving forwards. And it also has an effect in controlling the rotation of the knee. The one behind it is posterior cruciate ligament. So we abbreviate that because it's a bit of a tongue twister to ACL and PCL.
Okay.
So in answer to your question, do all ACLs need fixing? No. But it depends.
Okay.
And it depends on the risk of... There's a number of reasons why it's a good idea to have your ACL reconstruction. A primary reason for an ACL reconstruction, bear in mind, and we're not talking about ACL repair here.
Yeah.
A reconstruction means the ACL remnant is redundant and does nothing, so you reconstruct it with something else.
Okay.
And we can talk about how you do that later if you like, because that's quite an interesting subject in its own right.
Yeah.
So who should have an ACL reconstruction? Well, people who have symptomatic instability. So symptomatic instability means my knee gives way.
Yeah.
And that can be actual, i.e. you've ruptured your ACL a year ago and now my knee gives way, so I'm definitely going to have an operation. Or predicted, and it's predicted because we haven't really got to the stage where it's giving way yet.
Yeah.
So we've sort of got to go back a step. So what happens when you rupture your ACL? So let's say you're a footballer, you twist your knee, you hear a pop, it swells immediately, you carry it off or you hobble off, and then your knee's really
So it
sore.
does feel like a popping sensation when it goes, does it?
Yeah. It's often they hear it and you don't forget that day.
Yeah, no, it's a bit like your Achilles rupturing. It feels like someone shot in the back of the leg. So, does your knee feel unstable straight away with that,
well,
or
it can do.
Does the swelling kind of?
It can do immediately, but then afterwards you'll have just a painful, swollen knee, and you won't know what the diagnosis is. You'll just come along and say my knee's painful and swollen, and then part of the assessment would be: is this an ACL? Is it something else? Could it be a cartilage tear? Is it a dislocated patella? So I've had a lot of patients that I've seen in the clinic. I'm convinced it's an ACL rupture. Do a scan, it's actually a patella, and vice versa. A couple have had both. That's pretty unlucky. But then it takes about 6 to 8 weeks for the knee to settle. So it's still painful and swollen for some considerable time.
Yeah.
You may need a brace depending on what other ligament injuries you have, and then you may make a decision to operate early on those patients, but they haven't really had instability yet.
Right.
But
so what's stopping the instability early then? Why?
They're
just not functioning on it.
Yeah,
properly.
you just can't do what you need to do to make it give way.
Yeah,
because your knee won't let you.
Right.
So
okay.
There's a slight dilemma with these decision making: is do you let this patient go back to sport and see if their knee gives way?
Yeah.
Or do you just say, right, it's busted, we might as well fix it?
Right.
And those decisions will also depend on things like, have you torn a meniscus at the same time?
Right, okay. So the meniscus is the kind of half moon shape,
blue things.
Yeah.
Chunks of gristle that lie either side of your knee and act like a shock absorber.
Yes.
And about half of the patients that tear an ACL will also have a meniscus tear. And it's really important that you deal with the meniscus properly.
Right.
So we used to do a lot of meniscectomy. Anything ending in ectomy means remove, like appendicectomy. People have heard of that. But I'm a big proponent of meniscal repair now.
Okay, so you stitch it.
So you stitch it back because I want it to be there forever and heal and the patient have a normal knee afterwards.
And does that heal well, given it's kind of more of an inert structure it's not got a good blood supply, I assume?
Yeah, I feel like I'm saying depends with every question you ask here. Yeah, so that also depends.
Well, that's surgery, isn't it? It all depends on one thing or another.
It depends on where the tear is, and there are a vast array of different patterns of tear. If the hole in the meniscus is intact and it's torn right around the edge, then
Yeah.
that's the perfect one to repair.
Right.
Because the blood supply comes in from the edge.
Right.
So it's much more likely to heal.
That makes sense.
If it's pulled off the bone, we call that a root tear. That's also a perfect one to repair.
Yeah.
It's a tricky operation, and
so they're both where the blood supply is optimal for that structure.
and the meniscus is intact.
Right. Okay.
And the root repair we weren't doing 10 years ago. It's a relatively new thing.
Yeah.
It's a bad day when you have an ACL patient who's got a root tear and a meniscal repair on the other meniscal tear on the other side, and you might have to do another ligament. That makes your work for you. Yeah. Anyway, but that's what we're there for.
Yeah.
It gets more difficult when you get tears, for example, like my knee model here. There's a little flap tear. I mean, that's never going to heal in a million years.
Yeah. So
something like that you would just remove. Yeah, so there is a tear called a radial tear where the meniscus is split, and they are tricky to repair. So you have to put stitches either side of that. Okay. So again, we're getting a little bit too detailed here, but it just depends.
So basically, we're using your skills and knowledge to make a call on the day, really. I suppose you'll have some imaging to a certain extent, MRI imaging, that might give you that information, but I suppose it depends on when you get in there, you might have to make an intraoperative decision on what to do with it.
Yeah, so that's a very good point. So if we do decide, so going back to the original question is, who would you go for early surgery for? Anyone who's got a repairable meniscal tear, I would encourage to have early surgery.
Yeah.
But again, a lot of patients don't really want to have an injured knee twice. So let's imagine the scenario: you just injure your knee, you're just about recovering, then you go for 6 months physio, and then it gives way, and then you go, I need it fixing anyway.
Yeah.
So sometimes it's better just to say, well, look, let's get to 8 weeks, just get it fixed.
Yeah.
And then you're ill once.
Right.
And then you can get on with the rest of your life.
Yeah.
Because a lot of these patients are young, they want to be active, they want to get on with their lives, they don't want to have this to drag out for 18 months.
Yeah.
And bear in mind, it takes 9 to 12 months to recover.
So it's quite a long
to get
recovery.
back into your sport.
Yeah.
The other thing to consider is
because with footballers, they seem to be off for a small amount of time. Is that just because they've got high-end physio? Is it is it something? Are they doing something different? Is it just because they're fitter individuals to start with? Or am I just imagining it's a short piece of time? And
you're probably imagining it.
Right. Okay. This probably seems like a lifetime to them as a professional. But
the holy grail for professional sport is to get back quick.
Yeah.
Because it really matters. We know that if you get back at 6 months, you're more likely to re-rupture that ligament. And different countries have a different policy. So in Europe, they're a bit more aggressive, get people back at 6 months. Most of even the Premier League footballers don't get back till 9.
Okay.
You can get back a bit earlier, but the earlier you get back, the more chances of it going again. And if it goes again, that's catastrophic.
Is it? You can't just redo it.
You can, but it just gets more and more difficult.
Right. Okay.
And the chances of you getting back after a revision ACL.
Pretty limited.
I have got patients back after revisions, but it's difficult. And more complicated surgery. The other thing to think about in decision making about who to operate on is the risk of re-injury. So if say you've torn your ACL, you are now ACL deficient. So what does that mean? That means your knee's prone to give way.
Right.
And if you play a lot of sports, you're more likely to give way. So my old boss used to say you can live within the envelope of stability, which is doing things in a straight line, or you can have it fixed and do other things.
Yeah.
So what's the implication of that? The implication of that is if you're ACL deficient and you do cutting, twisting, turning sports, you may tear your meniscus.
Right.
And your meniscus, if you lose your meniscus, that's really bad news for your knee. So I know a number of friends of mine who've been treated conservatively, non-operatively, who've then torn a meniscus.
Yeah.
And then had their ACL done. Well, that might be
the wrong way around.
And there's some evidence that your chance of tearing meniscus is about 10% per year.
Yeah.
So 10% per year after 10 years is...
Yeah.
We could do the maths, 100%.
Yeah.
So after 10 years, you're pretty much going to have a meniscal tear.
Okay.
So I think that's a sort of secondary reason, certainly in younger patients. And so I work 2 days a week at Sheffield Children's Hospital, and we are seeing now an epidemic of paediatric ACL injuries.
Right. What's driving that then?
Which is it's an interesting subject. We don't really know. The hypothesis is that we're 70s children. I know I don't look it, but we are 70s children.
So we were playing out more.
You look it. But anyway, so we were playing out more, playing more non-competitive but general sporting activity.
Probably with a lot of twists and turns and doing crazy things, jumping out of trees and all sorts of things.
But we played less organised competitive matches.
Right.
Whereas kids today spend most of the week on their Xbox,
Yeah.
but then they have these really intense matches with a ref, a linesman, granddad, grandma, auntie, uncle, mum and dad, all screaming from the side. And what we know is that injuries are more likely to occur in a competitive match when you're really trying your hardest and trying to do your best. So it's partly that, partly the incidence is rising, partly it's more being recognised more, so there's more access to MRI scans, and then weight may be a factor. Certainly there's more girls playing football and sports, and we know that female athletes have a higher incidence of knee injuries.
Interesting.
Which is the next subject that we should talk about, really, because that's really in the public domain. After all the England players that have torn their ACL, England female footballers, that is, why do women have a higher incidence of ACL
Why is
injury? Again, we don't really know, but I did log on to a seminar recently that was held in Barcelona, which was purely about ACL injuries in female athletes. There are a number of theories about this. Now, part of it is purely anatomical. So females' ACL is not as strong as a man's ACL. Their muscles aren't as strong. Their anatomy is slightly different. If you have a wider pelvis, you're more likely to have what we call a valgus or knock-kneed shape of your leg. You may then have a more of an internally rotated moment, more prone to that twisting your knees in,
and that's what
and then your foot goes out. So when you tear your ACL, it tends to do it does this. So you often stretch your medial collateral ligament, and then the tibia and the femur sort of become disconnected, if you like, and the back of the femur touches there, and it's like it's what we call a valgus moment. So your foot points out, and your knee goes in. So it's also rotational element
playing
to
football as well. You've got boots on, and the studs are in the ground, which stops the movement of the foot.
Exactly.
And then everything transfers up and twists straight through the knee because that's the next weak point.
And 90% are non-contact injuries.
Right.
So it's not a tackle usually. It's just running along the ground. Then one of the best examples of an ACL injury is Michael Owen's injury, and I think it was 2002 World Cup. Yeah. And they really slowed it down and focused on his knee, and you can see it pop.
Oh.
And
I hate looking at those videos.
If you Google that, that's a really good example of what happens.
Yeah.
So if you and then there are other theories like hormonal theory. But from what I can gather, that's very difficult to prove. And the problem with female hormone cycles is what you're supposed to have and what you actually have when you're an athlete are not the same. And so based on that conference I attended, I don't think that's irrelevant.
Is that to do with ligament
laxity?
Yeah, but funny enough, they talk about that with why women have more bunions than men because because of pregnancy and relaxation hormones and all the rest. That was one theory, because it is true, and we know it's not necessarily to do with footwear, but that's an interesting theory, really, that you're kind of saying.
But
you don't really know whether
I don't really believe that, because they measured. I think it was in Barcelona, somewhere in Spain. They'd measured the hormones in their female athlete.
Yeah,
and when you were supposed to have luteinizing hormone at one point and then more progesterone another, but it was so unpredictable. And those hormones, because they're elite athletes, they don't have a normal menstrual cycle, they don't have normal hormones, and so how can you really draw a conclusion based on monthly cycles of hormones? If it was pregnancy, it might be different because that's 9 months, and so ligaments do stretch out over 9 months. But really we don't know. If you listen to Nike will tell you it's due to football boots, and then they want you to buy a £300 female-specific football boot. I'll let you draw your own conclusions about that.
Yeah. Follow the science, Follow the science.
So I think we are, and so what? So none of this really matters until there's something you can do about it, isn't there?
Yeah.
And there is something you can do about it, and what you can do about it is you can retrain your body to try and prevent the incidence of ACL injury.
Okay.
And so there's
after the injury.
Before and or after.
Okay.
So there is something called Power Up to Play, which is a paediatric initiative to reduce the number of ACL injuries in children.
Yeah.
And then there's a PEP program which was developed in America, which has been introduced. And what these are training regimes for children and or adults to do before they play. To make their muscles stronger so that they can reduce the rate of injury. And the evidence suggests you can reduce the rate of injury by about a half.
Right, okay.
If you do these 4 sequences of exercises before you start playing.
Yeah, okay.
And I think we should really be pushing that
as a focus.
It should be compulsory, really, particularly for high risk individuals.
Of course, if you have ruptured it, I mean, you guys have kind of become masters of minimally invasive surgery. I know I'm now starting to do more minimally invasive surgery through a different kind of mechanism, but yours is, rather than opening the knee up and making a big, incision to the knee and causing soft tissue trauma, you're doing it with a camera inside the knee, which has got to be quite fiddly. How do you physically fix an ACL? What do you do?
I say to my children that my job's great. It's like playing video games. So I sit there with controls and look at a screen, and that's what they do most of the time. So how do you do an ACL? Well, and again, that all depends on what graft you use. And whilst Tony's alluded to doing it keyhole, you might end up with a big incision or a reasonable size incision if you have what we call a patellar tendon graft. So there are a few patients, or certainly high risk patients, I would choose a patellar tendon graft for.
Right.
Which is a bigger cut down the front of the knee. A lot of patients will have a hamstring graft, which can be harvested through a small incision, and we take 2 tendons and fashion that into a ligament. There is another graft you can use called the quadriceps tendon graft. There's some drawing on my knee model, but the quadriceps tendon graft can come with a bone block of the patella, and then it comes up. I really like the quadriceps tendon graft. It is a rock solid graft. So we can discuss, we discussed at the time the options available. The second thing is that we're adding more and more in a second operation. So there's something called a tenodesis, which is a cut on the outside of the bone, which has been shown to be like a belt and braces technique.
Right, okay,
so a study in Canada showed that would reduce the failure rate from hamstring ACL reconstructions by a third to a half. So the actual technique is done, again, as you say, with keyhole surgery techniques. You'll remove whatever's left of the ligament, ACL stump. You prepare what we call the lateral wall. You drill a hole in the femur, drill a hole in the tibia. We have special guides to position that, and then you'll pass the graft in. And then it's either fixed with screws in the tibia and the femur, or potentially a button on the outside. And there are different options available.
So is there any detriment to the structures you've taken the graft from once you
so what you're talking about is donor morbidity.
Okay.
So you're donating tissue from yourself back to yourself, if you like, and so we call that donor morbidity. So the reason why hamstring tendons became very popular is because of the lack of donor morbidity.
Right.
So they didn't have many problems with it.
You're not taking the whole hamstring, are you? It's just part of it.
You leave the muscle, but you take the tendon.
Oh, the whole tendon, right.
So pretty much the whole tendon. And they can be 20, 24 centimetres long.
Right.
So it goes right up into the thigh. And so patients will complain of pain up into their thigh. Yeah. There is a nerve quite close by that you can sometimes bruise or injure. And you can get pain, twangs. It feels like, something sometimes goes, a bit of scar tissue forms and it can pull again. Very, very rarely you can get a persistent problem with hamstrings.
I suppose people will be thinking, though, but if you've taken the whole tendon and that's not there anymore, that has a function. Do you not miss that tendon? Does it not affect your knee function?
So there's a lot of interest in this now, and that's partly why I've been looking at other graft choices. So for certain athletes, I think you miss the tendons.
Right.
But we're talking very high-level athletes.
Well, why is that? Is it
so explosive jumping athletes will
right.
if you measure it, the hamstring function is down.
Right. Okay.
Bear in mind there are many professional footballers that have had this done and been fine and got back to playing high competitive sport, but not everyone does.
Yeah.
So if you measure it on a clever machine, if you're an Olympic triple jumper, I wouldn't do it.
Right.
I treated a British champion gymnast recently who was, and I thought a hamstring graft would have been a bad choice for her.
Yeah.
She was skeletally immature, so her growth plates were still open, so I didn't want to use a patellar tendon graft. So for her, I use a quads tendon graft.
Okay.
And she's doing really well. She's not yet back doing full sport, but she's nearly there, and she's about 9 months down the line.
Oh, okay.
So I think when you speak to a surgeon about ACL reconstruction, you should speak to one who knows about all the grafts, can offer all the grafts, and isn't just a one-trick pony, because every patient is different, and I think you need to be able to offer more than one operation.
Yeah, sure, that makes sense.
And going back to your question about donor morbidity, so the patellar tendon graft was the original graft that we did ACL reconstructions with, but there was an instance of what we call anterior knee pain, which was kneeling pain, so it hurt to kneel on, and that can be permanent and incurable. And so again, so if you're a carpet fitter or a joiner, I probably wouldn't offer you a patellar tendon graft because that might risk your job, or life could become difficult. But there are other things you can do.
Yeah. Okay.
So that is they're the main reasons for.
So are there any kind of synthetic grafts? I know sometimes around the ankle we'll use something called the internal brace, which is like a fiber wire material that you attach and drill in, and then you can kind of beef it up with the remnants of a ligament. Have you got the same in the knee, or is it not strong enough? Have you not got to that point?
They do exist. I personally have antibodies to artificial ligaments within the knee. The way I was trained was you should have a biological graft, which then can revascularize and become part of you again. So I don't use artificial grafts within the knee. They do exist. Not many people use them. I think there are so many good options. Bear in mind, you've got 3 graft choices in one leg, and you can always use the other.
Yeah, sure.
So you've got 6 good options without having to use anything artificial. Where artificial grafts, I see a place for them at the moment is for the collateral ligaments.
Right. Okay.
So that would be the side ligaments.
On the outside.
So if you've ruptured your lateral collateral, we call that part of the posterolateral corner, or your medial, and there's a lot of interest in the medial ligament at the moment, particularly in soccer players, because we used to leave the medial side and not treat it in association with ACL. But some recent evidence has suggested that these need to be treated because your failure rate with untreated MCL is much higher, up to 12 times higher.
Right.
In the I think it's Norwegian registry somewhere in Scandinavia. So there's a lot of, we are being more aggressive with MCL injuries in association with ACL. These are not acute injuries normally. These would be chronic. Acute means recent, chronic means long term.
Okay.
So I would use artificial on the medial side, sometimes on the lateral side, if I didn't want to take a hamstring tendon or I couldn't use a hamstring tendon.
Yeah. Okay. So, I mean, occasionally, you do a lot of arthroscopies on their own, so just putting a camera in and having a look about. And Jonathan Redden always used to say it's a bit like letting the demons out. So, does an arthroscopy actually do anything? I mean, is it no better than a sham operation that some studies have suggested?
So, it's a very good question, Tony. So arthroscopy did get panned in the press about 10 years ago. There was a study published in America where they did exactly that. They did a sham operation, just made a cut in one group of patients, and the other patient, they did the operation, and there was no difference. Yeah. And so that's all about patient selection. And so really there's no place for knee arthroscopy when you've got severe arthritis, unless you're very specifically going for something like a big loose body. Yeah. And so washouts were commonly done when I was training, no place for that. So if you come to me and you've got bone-on-bone arthritis, you'll get offered an injection or a knee replacement.
Right, okay.
But you won't get offered a knee arthroscopy, unless there's something I'm really not sure about on your MRI scan or your X-ray. So yes, so you should only really have an operation if it's indicated. Yeah. Now sometimes you come back and you have, let's say you've injured your knee, you've got pain on particularly the outer side of your knee joint, and your MRI scan's reported as normal. We look at it and we think, is it normal? I re-examine you. You still got pain. What do you do then? Well, we know that MRI scans can miss certain tears, and particularly on that lateral meniscus, that the outer side cartilage, the incidence of missed tears can be up to 20%.
Oh, that's quite high then.
And so I often do look inside knees with normal MRI scans. Right. And if you have had a normal MRI scan and you've still got pain, it may not be normal. Right. I think that's an important take-home message. Yeah. You could have what we call a very peripheral tear. So if you've got a tear right around the edge at the back, the MRI scan will look normal because it
can't
just
quite see it. Yeah.
It's taken when it's straight, and so it just sits back into a normal position. In children, there's some evidence that you can do the scan in different positions to see if there's a hypermobile, like a lateral meniscus. That's the outer shock absorber, which can move around a lot, but it's not commonly done in the UK.
Right. Okay.
So yeah.
All right. So before we kind of get to the surgical side of things, there's a lot of conservative options available to us. Certainly in my field, there's loads of different conservative options, whether it's from orthotics or supporting the foot or injectables. And from an injectables point of view, we tend to use either a steroid, which is often a go-to, or a hyaluronic acid-based thing to give shock absorption to a joint. There are some new ones. I think I did message you about this one. It was about £3,000 injection that I'd never really heard of. What are your thoughts on injections? What sort of things do you use?
So the most common and the most effective injection is still a cortisone injection. Now, we have to be a little bit cautious about that because there is some evidence that lots of steroid injections can damage your knee joint. But if it's already worn out, what have you got to lose?
You're not really losing anything, are you?
And I often use an injection as a boost. So it's not always a long-term solution, but it can give you a boost. So let's say, for example, you've got a bit of kneecap arthritis, you may be a little bit overweight, you've lost a bit of condition, your knee hurts. Then you get into this downward spiral where your knee hurts, your muscles get weaker, you put more weight on, your knee hurts, your muscles get weaker, you put more weight on, you're down, 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 down. You need something to break that cycle. And simple cortisone injection can be brilliant in this circumstance because it gives you the opportunity to climb out. You've probably already seen a physio. The physio says, there's nothing I can do because you can't do it because your knee hurts.
Yeah.
So you're stuck.
It's catch-22,
stuck between a rock and a hard place. So I like to do an injection and physio.
Right.
And you really got to do it.
Yeah.
Whilst the injection's working. And then the injection wears off and actually, lo and behold, your knee's better.
Yeah.
And it stays better for longer than the injection can really affect your knee for. Normally, injection wears off after 4 months.
Yeah.
So that's a cortisone injection. Hyaluronic acid injections. So I do some. I think the results are a little unpredictable. The evidence is a little difficult to unpick. The one that I offer is either a single injection, which has got a bit of steroid in it, and it's also got the highest dose of hyaluronic acid on the market. So you have to look at all the different products on the market, and that's got the highest dose. And then there's another one called Monovisc, which we use, which is the same as that, but without the steroid.
Okay.
And I've had some very good results with it. What can you say about it? Is it's safe? It's not going to do you any harm.
Yeah.
And that's a good place to start. So I've had patients that have gone down to London.
Yeah.
And there is a huge industry around injecting stuff into the knee. And some of it is bad medicine. Really.
Yes.
And for example, there's something called lipogems, which is fat, which is spun down in a machine and is stuck in your knee. How that can help, I don't know.
How do you get the fat?
Well, most people have got quite a lot of donor tissue.
Yeah.
You get it from your body.
Yeah, but how do you physically get it?
So you make a little incision and you take it out.
Oh, right. So it is an incision, not
actually, I thought it was all garbage. So maybe you just do a needle. I haven't really looked at it.
Right.
A little incision or a needle. I can't remember.
I suppose they're thinking that it'll act as some sort of cushioning, but I am struggling myself to think how that would really work.
Yeah. So that's the one example. Other example, stem cells. Patients seem to remember stem cells.
Yeah.
That seems to be an in word. So that's taking immature cells in the hope that they'll then differentiate into mature cells.
Yeah.
So stem cells are basically cells that can turn into anything else.
Yes.
Like a nerve cell, a cartilage cell, a muscle cell. They've got that programmed into them. And so that's a buzzword. People seem very keen on that idea.
And I suppose that's always the danger in private medicine, isn't it? Because buzzwords sell, don't they? That's what. And then
it's a big industry.
If you do have somebody who isn't quite as honest as you would like and likes to do things just for the sake of money, you could find yourself spending a lot of money without a lot of benefit.
Yeah. So and then there's another. So the injection you touched upon is arthrosamid, which has been heavily marketed recently at knee conferences that I've been to. The first thing he said to me, the company representative, was, in its monomer form, this is carcinogenic. Right. So a monomer is a small molecule, and this is a polymer. So it's lots of monomers joined together to make a polymer. Yeah. So it's like a chain.
Yes.
And that put me off.
Right. And it doesn't sound like a great way to start to sell something, does it?
And then it's permanent as well. So you inject it into the knee, and it acts. I don't think it acts like they thought it would. It sort of just stays there in the knee, and then you get a synovial reaction around it, and it's supposed to alleviate your pain. I'm not going to offer that treatment until I'm very certain that there's very good evidence that's not sponsored by the company that that's the right thing to do. I've treated one patient. I've seen one patient who's had it. It's not really permeated up into the north much, but I've seen one patient that had it, and he came to me for an operation.
So does it make the operation more difficult if there's something permanent? Is it creating is it scar tissue or something that causes you a problem as a surgeon?
I don't know, because that patient had an osteotomy, so I didn't go into his knee joint.
So
that was below the knee, so I'm not sure. but I wouldn't do arthrosamid. The other thing to say about injections is there are blood products that you can inject.
Yeah, so PRP
or the Dulux PRP, which is Enstride.
Yeah.
And I do like Enstride, and I think there is a place for Enstride. So PRP is platelet-rich plasma. Enstride is a sort of super deluxe version of that, where you take blood from a patient, about 60 mils of blood, you spin that, you'll spin it again, it releases all the growth factors, cytokines, inflammatory mediators, and then that's injected into the knee joint.
Okay.
And there is some evidence that Enstride does help. I think it helps more in patients who've got lesser degrees of arthritis than the ones that have got end-stage arthritis.
Yeah.
But, in some, again, it's safe. It's a shot to nothing. If it works, great.
Yeah.
And you haven't really got much to lose.
Okay. So in terms of other soft tissue problems, I've heard you talking about Baker's cyst. And Baker's cyst is something that I've come across when I've been doing popliteal scans in terms of doing nerve blocks. And patients sometimes say, I've got a Baker's cyst in there, so you need to be careful around the back of my knee. And a lot of people have them, they just don't cause them any problems. So I suppose my question is when does that become a problem? Why is it called a Baker's cyst? Is it named after a baker? I presume it is. And what sort of problems do patients get with them? Because you hear about them rupturing and causing other issues. So is it sometimes pain, or is it just when they rupture that they cause problems?
For some reason, I can't quite explain myself, Baker's cyst has become a bit of an interest of mine. And I have now got quite a large series of patients that I've treated with Baker's cysts, which I'll come on to in a minute. So a Baker's cyst is otherwise called a popliteal cyst. And the popliteal fossa is the back bit of your knee.
Yeah.
And all it is a bag of fluid at the back of your knee.
Yeah.
And so the knee joint's covered in what we call a capsule, which is like a bag or an envelope that contains the fluid in the knee joint. And there's always a drop of fluid in your knee joint. Now, people who have a Baker's cyst have a little valve at the back of the knee between two muscles, and so fluid can just escape. And then it acts like a one-way valve, and the fluid can't get back into the knee.
Okay.
It can fluctuate in size depending on activity levels and what you do. And then they can grow, they can sometimes shrink, sometimes the pressure gets so good it forces it back into the knee. And most people just live happily with their Baker's cyst, and it doesn't cause any problem. But there are a group of patients, and I think they are the minority, who have symptomatic Baker's cysts. Now, I'm not saying that everyone needs an operation on their Baker's cyst. I'm definitely not saying that. But there are a group of patients who have symptomatic Baker's cysts. Yeah. If you go to your GP or your local knee surgeon, he'll probably say there's no point doing anything.
Nothing you can do with it.
It's not worth it. But I looked into this a lot because I had a patient who was really troubled by their Baker's cyst. So you get pain, you don't like the swelling. It can be very disabling. If some of them are huge, some of them have loose bodies in them, so it feels like you've got a bag of marbles at the back of your knee, and they can rupture also. So if a ruptured Baker's cyst is like a grenade going off in the back of your knee.
Yeah. And
people used to think that if you rupture it, it'll go away, but it won't, because it's just the cyst that's burst, and you've still got the valve at the back, and so it can still keep going.
Yeah.
And so historically, we were taught as registrars either do nothing or try and remove it from the back. Well, removing it from the back is a big incision, an S-shaped incision right at the back of your knee. And even then, the recurrence rates are very high because it's very difficult to get right down to the valve. So my technique is to look inside the knee.
From the back or the front?
So look from the front. I drive the scope, the camera into the back of the knee. I make a separate incision at the side, on the inside, and then I'll take the valve out from the back.
Yeah, okay.
And I've done 54 of these.
So you're not taking the whole cyst out?
No, so I leave the cyst. We can actually see the cyst. So I drive the scope into the cyst and have a look.
Right.
But we don't take it out. We just leave it. Because
that's interesting.
If there's no valve, there's no pressure.
Yeah.
No pressure, it doesn't matter if you've got a cyst.
It makes sense to shut the valve off, doesn't it?
Yeah,
really?
so the fluid can just then transfer backwards and forwards, but it doesn't build up that pressure, and it's that pressure that causes problems. So I'll give you a couple of... So we've recently reviewed these patients, and we presented our 54 patients at the Registrar's Day meeting. And the first thing is, one of the things you'll be told, or you may be told about your Baker's cyst, is it's too dangerous to remove because it's near the artery.
Yeah.
Well, first thing is we hit no arteries or veins or nerves during the operation.
I suppose if you're coming in from the front, it's below...
But there's it's actually not that close to the artery.
Right,
the valve isn't, but people think it is. Yes. And so if you look at the scans, it's not. There's a big muscle belly in the way.
Right, okay.
So it's not that close. And we didn't hit any arteries, so that's good.
Yeah.
And then what was our recurrence rate was about 7 out of 54. But of those, we thought that only one was really significant.
Yeah.
So recurrence depends how you measure success. But if you're not taking the cyst out and you do a scan, the cyst will still be there.
Yeah.
But the patient will say, well, I can't feel it. Doesn't matter.
Yeah.
So we thought only one of the 54 patients had a symptomatic recurrence of the cyst.
Right.
And
okay.
I'll give you a couple of examples of the patients we treated. One patient had an attempted open excision. 3 aspirations, so needles going in, withdraw the fluid. That didn't work. It always comes back.
Yeah.
And then this open incision, massive incision, came back and got infected. And then she came to me for a second opinion, and we did it arthroscopically, and she's absolutely delighted.
Oh, great.
There was another gentleman who we spoke to who had symptoms for 8 years, was told there's nothing that could be done. We debrided it arthroscopically. He says it's come back, but it's a tenth as the size as it was, and he's really happy with it.
Yeah.
So it can be done. It's a relatively safe. It's not that easy to get over because we cut away tissue at the back of the knee. A lot of fluid does go into the calf and around the leg. It can be a bit stiff and painful.
Yeah.
You can get a little bit of bleeding from the inside cut we make, which is a slightly irritable portal. So I'm not saying it's without any minor morbidity or minor problems initially, but normally it all settles down.
So why is it called a Baker's cyst?
Oh, Baker's cyst. I think it's Mr. Baker who describes
it. It's nothing to do with Bakers who bake
Bakers,
cakes,
no.
right?
I think it was a Mr. Baker.
I think it was something bakers must do because we have a tailor's bunny on the outside of the foot, which was apparently because the tailor sat cross-legged, but I think it was probably an urban myth.
I think it's Mr. Baker.
So one thing I do need to just touch on in terms of conservative therapy. So foot position and knee pain. There's a whole industry of podiatrists who specialize in biomechanics, who treat knee pain with orthotics, but I've never really known you to refer, or you might do, and I just don't know about it, for that type of treatment. Is that something you don't really see a link to, or what's your thoughts on that?
I think it's over-egged.
Okay.
So I've heard this a lot from physios, that your foot's overpronated, so that's having an effect on your knee.
Your foot bone's connected to your ankle.
It
bone
is,
and so on
but
and so
also,
forth.
but it's also connected to your hip bone, and I'm more worried about the joint above rather than joint below. And so, as part of my assessment of the patient, I'll be looking at rotation. See, I think these problems are probably due to low limb rotational malalignment,
right?
And that's causing the overpronation of the foot. Rather than the overpronation of the foot being the primary problem.
Right. Okay.
So we see a lot of this sort of rotational malalignment in kneecap problems.
Yeah.
So if you have a recurrent kneecap dislocation, so your kneecap pops out like this, it's a very complex problem, and there's a number of factors that can lead on to that. Like your femur might be twisted in.
Yeah.
Your tibia, your shin bone might be twisted out. You may have a deformity of the bones, like a knock-kneed or valgus deformity.
Yeah.
You may have a high patella, a shallow trochlear groove, weak soft tissues, weak muscles. And so I've sort of digressed a little bit.
Yeah.
But my theory is, I think these issues are more to do with the rotation and more to do with the hip.
Yeah.
And so I will assess the foot, but I think the hip's more important.
Because I know
some
of my colleagues, when we're talking about kind of medial and lateral compartment arthritis, use orthotics with wedges to try and offload one side of the knee compared to the other. Is that useful, or in your opinion? Or?
Yeah, so we did touch on conservative treatments for arthritis, and we always obviously only offer operations when absolutely necessary, and we should always exhaust non-operative treatments first. So I think what you're talking about is an offloader knee brace. Are we talking
they were talking about foot orthotics with wedges, but
I would rather go for an offloader knee brace.
Okay.
So if you've got knock-kneed or bow-leggedness, and that's caused arthritis, then what you can have is a brace which will try and offload the disease compartment.
Right, okay, which makes sense.
That compartment's disease, you can have a brace which does that.
Yeah.
So it overloads the outer half and it relatively spares the inner half. And I think we probably don't prescribe enough of offloader braces. I think offloader braces work very well.
Right, okay.
In select patients. The thing about our braces, if you don't like it, just take it off.
Yeah.
Whereas if you have an operation, you don't like it,
you
that's
can't
a bit
go back.
more tricky.
Yeah, it is an end stage.
This is actually an example of a brace, but this isn't an offloader knee brace. This is a custom-made I think this is an ACL brace for skiing.
Right.
So people often will ask me about, I've injured my knee skiing, can I go back skiing? So I normally will say to them, you can't go back next season.
Yeah.
Unless you don't have an operation, then you can. But I usually advise them to wear a brace afterwards.
Right.
And I think if you're going to get a brace, you should go for a very good one. And custom made means it's made to measure for you.
Yeah.
So you'd be sized, measured for it, and then it'll be manufactured for you. I was lucky enough to go to this company's manufacturing site, which is in near San Diego, just over the border in Mexico,
nice. Yeah.
which was a nice trip. So I know that they're made to a very high standard. And if there are problems with it after you have it made, you can always send it back and they'll remake it.
Right, great stuff.
So I would normally recommend that. Although again, braces are a little bit controversial.
Yeah.
And if you twist, you can still twist your knee in a brace, but I think it definitely controls the side-to-side movement.
Yeah, makes sense. Well, thanks very much, Paul, into a fascinating tour around the knee. And if patients want to get hold of you, how's the best contact? Well, how can they follow you?
So I'm part of the Coriel Orthopedic Group, available at the Coriel Clinic. I do clinics at Park Hill and Thornbury, and at the NHS Trust at Doncaster Royal Infirmary, and Sheffield Children's Hospital, of course.
You can check out our website, and Facebook as well, for Paul Haslam, knee surgeon. Okay, thanks very much.
Thank you.